All right, you mentioned, mentioned briefly hormone therapy. So let's go there. I think that's where the brain goes first when you hear the word menopause. So let's both address hormones.
So part of hormones, everybody goes to menopausal hormone therapy, but there's another hormone therapy as well, which is oral contraceptive pills. And so when women are in their early 40s and going through these swings in estrogen, sometimes, and yes, we do use birth control pills now in women in their 40s, a birth control pill is, the way it works is it basically shuts down your own estrogen and progesterone and gives you a steady amount of estrogen and progesterone every single day. And so that might be a way of managing some of the symptoms when you are in perimenopause and you're going through the swings in hormones. Now, when we talk about menopausal hormone therapy, and notice I'm not using hormone replacement therapy, I like to go into the history a little bit, and part of it, I was a history major in college. And what I like to tell people is, in the 60s, when pharmaceutical companies figured out how to make estrogen, someone's like, you know what, let's give this to some postmenopausal women. They feel great, except for they develop uterine cancer. And so it went from, okay, we're going to give people estrogen to, yeah, let's not do this. Until the 80s and 90s, when pharmaceutical companies started making progesterones, and they figured out, hey, if we give estrogen, progesterone, women do not develop develop uterine cancer. Now, I was a resident in the 90s. I was in med school in the 90s, and I can remember when literally our advice was, we're just going to give it to everybody. It's going to change the world. Women won't get cardiovascular disease. They won't get dementia. And then, as you all know, 2002 ended that. And in the last 20 years, when we look at how we give menopausal hormone therapy, we give it mostly in a patch or a gel form. And the reason for that is oral estrogens, as we found out in 2002, can increase your risk of blood clots because in order to get processed, they get processed through the liver. So the safety has improved because of our delivery mechanism. Progesterone, we now use prometrium, which is actually the progesterone molecule. It's a little bit weaker than some of the progesterones, so hopefully does not increase the risk of breast cancer, but it's strong enough to prevent uterine cancer, which is what we want to do. Sometimes we can do, that's kind of our basics. There's other ones. Duvet is out there, and that's an oral estrogen with SERM, which is like a tamoxifen, so it's kind of an estrogen antagonist and agonist. There are, again, oral. There is a ring you can put in your vagina. So those are the ones for systemic estrogen use. Now, vaginal is a completely different animal. And the reason why is we have low-level estrogen products that are not reabsorbed by the body. In other words, it is safe to use even in breast cancer survivors. And vaginal estrogen can be found in a cream, it can be found in a pill, it can be found in a ring. And that can be used throughout a woman's lifetime and has wonderful benefits.
I noticed you made it clear that you didn't call it hormone replacement. Is this a different way of thinking, or is it just a totally different ballgame now?
So part of it is in the 90s, the pharmaceutical companies called it hormone replacement as a marketing term. You're deficient in a hormone, so we're going to replace the hormone. When you're on menopausal hormone therapy, we're not replacing the estrogen. We're giving you a little bit of extra estrogen to bridge that transition from going through perimenopause, where you have these highs in estrogen, to menopause, where no longer your ovaries making estrogen. You still get estrogen from other parts in your body. You get estrogen from fat cells, and you get estrogen from adrenal cells. So it's not that you're lacking estrogen. You just are lacking estrogen from the ovary. And so the purpose of menopausal hormone therapy is just to give you a little extra estrogen to bridge that gap until your estrogen receptors get used to not having as much estrogen.
All right, Dr. Diggs. Oh, go ahead.
And actually, I was going to ask, so Dr. Vasavada gave a great analogy of jumping into cold water, and I'm going to steal it from you. So will you share it for my patient? Please share. But it was such a great way of thinking about what the medications are for.
So what I tell a lot of women in my office is menopause is like jumping into a cold pool. Initially, your body's going to be in a little bit of shock, like, what the heck is going on? But the longer you stay, your body's going to get used to that cold pool. The purpose of menopausal hormone therapy is to build steps. So you can sit on the steps, let your legs dangle a little bit, get used to the cold water, and slowly and gradually get into the pool. With time, your body is going to get used to not having as much estrogen. But the purpose of menopausal hormone therapy is to bridge that gap.
All right, Dr. Diggs, for those, hormone therapy is not an option.
So I'll echo that vaginal hormone therapy is an option for everyone. It should be. I've got women in their 90s on vaginal hormone therapy or vaginal estrogen, and it can help decrease urinary tract infections. It's a miracle drug that should be available over the counter. So separate from the systemic hormone. But some women really cannot take menopausal hormone therapy, whether they've had blood clot risks, whether they've had estrogen receptive cancers, whether they have very high risk of heart disease. There's medical reasons why systemic hormones can be dangerous in certain populations. And so in those women, there are other options that are non-hormonal to treat symptoms like particularly the vasomotor symptoms, those hot flashes, whether it's low dose antidepressants, SSRIs and SNRIs, different categories. There's actually a newish medication that's a non-hormonal therapy that can be used if hot flashes are particularly bothersome. And so even if hormones are not an option, it doesn't mean that there are no options, but that's something to talk about individually with your physician.